So we're going to continue with the lungs and lung capacities and look at the volumes. So lungs are soft, spongy, cone-shaped organs of the respiratory system, separated medially by the mediastinum, call that the mediastinum space, and enclosed by the diaphragm, which is down here, and the thoracic cage, which is 24 ribs and a sternum. Occupy most of the thoracic cavity. A primary bronchus and large blood vessels enter each lung on the medial surface, which is here. Let's see if I can get this. Now, the lungs, they have a double layered serous membrane. So the visceral pleura is the inner layer attached to the surface of the lung. Then you have a parietal pleura, which is the outer layer, which lines the thoracic cavity. And you have serous fluid that lubricates the pleural cavity between the two layers. Okay. The potential space between the visceral and parietal pleura is the pleural cavity. No significant space actually exists. The pleural cavity contains a thin film of serous fluid, consists of mostly water and enzymes that lubricates adjacent pleural surfaces, reducing friction as they move against one another during breathing. This fluid also helps hold the pleural membranes together by creating surface tension. As I mentioned, if there's inflammation, this can dry out and it can be like rubbing sandpaper together, and it can be very, very painful for the patient. How do we treat it? Pain medication, anti-inflammatories, high doses of corticosteroids, which would be anti-inflammatories, and depending if it's bacterial, then antibiotics. If it's viral, then there really aren't too many antivirals out there that can help with that. The right lung is larger than the left. The right lung has 3 lobes, superior, middle, inferior, and the left has 2 lobes, superior and inferior. So lobular bronchus supplies each of the 5 lobes of the lungs, and each lung contains air passages for the alveoli, nerves, blood vessels, lymphatic vessels, and connective tissues. So if you were to take a transverse cut and look at the lungs, here is your vertebrae. Okay, here is your aorta, esophagus. The heart sits right here, so in between the lungs, here's the right lung and the left lung, and then you can see the visceral pleura, which aligns right against the lungs, and then you have the parietal pleura on the outside, and in between you have this pleural cavity with this serous fluid, which will help lubricate. And as you take a deep breath in and a deep breath out, it helps lubricate the area. Again, if this dries out or is inflamed, then it can be very painful for the patient. So just kind of a review for parts of the respiratory system. You've got the nose, the nasal cavity, the paranasal sinuses, the pharynx, the larynx, the trachea, the bronchial tree, and the lungs. What's the purpose of the nose? Nostrils provide entrance to the nasal cavity. The nasal cavity conducts air to the pharynx. Mucus lining filters, warms, and moistens the incoming air. What do those paranasal sinuses do? They reduce the weight of the skull, serves as resonant chambers. The pharynx is the passage for air moving from the nasal cavity to the larynx, and for food moving from the oral cavity to the esophagus, so that's the common opening. The larynx is the passageway for air, prevents foreign objects from entering the trachea, and the epiglottis is what shuts. The trachea is a passageway for air. Mucus lining continues to filter particles from the incoming air. The bronchial tree conducts air from the trachea to the alveoli, and the lungs contain air passages, alveoli, where gas exchange takes place. Now the mechanics of breathing, movement of air and from outside the body into the bronchial tree and alveoli and back out, composed of inhalation and exhalation, so air moves from higher to lower pressure. Atmospheric pressure, pressure exerted by the air on all objects in contact with it, forces that moves air into the lungs. When pressure inside the lungs decreases below atmospheric pressure, air flows in from the atmosphere. This occurs during inspiration. So let's say it's 761 outside and 760. Well, we always go from high concentration to low concentration, so that's air will rush in. If air is 762 in the lungs and 761 outside, then air will go from high concentration in the lungs to outside, and that's inhalation and exhalation. So air is moving from high concentration to low inside, and then from high concentration to low outside. Increasing the volume of the thoracic cavity causes air pressure inside the lungs to decrease. Your diaphragm is here, and your external intercostal muscles are here, muscles that expand the thoracic cavity for normal inspiration. The diaphragm contracts and moves downward, enlarging the thoracic cavity. External intercostals contract to move the ribs and sternum upward and outward. Muscle contraction results in pressure in the lungs falling to 2 millimeters below atmospheric pressure. This causes air to rush into the lungs. Okay. Maximal inspiration. So a deep breath requires contraction of several muscles. So your pecs, your sternocleidomastoid, your scalenes enlarge the thoracic cavity even more. So these are your accessory muscles of breathing. Due to surface tension between the two layers of the pleura, as the thoracic cavity expands, the lungs will expand with it. Surface tension, however, is not advantageous in the alveoli. It would tend to cause alveolar collapse. So as the lungs expand in size, a lipoprotein mixture called surfactant keeps the alveoli inflated, preventing their collapse. Now, if kids are born too early, around the 32-week mark, their alveoli are not yet producing enough surfactant, and it can be very difficult for them to breathe. So a lot of times for premature babies, they can give them artificial surfactant until the body starts making their own surfactant, so that they can breathe. But a lot of times premature babies do have difficulty respiratory issues later on for being born, usually premature. We can go into that a little bit more later. So again, so atmospheric pressure is 760 milligrams of mercury. The alveolar pressure, as you take a deep breath in, diaphragm, this will drop. As it drops, then air will rush in. Okay, and then if the air increases here, it goes from high concentration to low concentration here. So again, you're always going from high concentration to low concentration. So let's say it's 760 and 759 here, then we're going to rush in. Let's say it's 761 here and 760, we're going to go from high to low. So again, maximal inspiration, you're going to need external intercostals, diaphragms, scalenes, sternocleidomastoid, and the pec minor. So these all muscles will work to take air in. So normal expiration, if you look at expiration, results from passive process of elastic recoil. So if I breathe in and just relax, well, I'm going to expire. Forceful expiration requires your abs and internal intercostals. So that's the difference, right? So if I take a deep breath in and just relax, well, that's normal expiration. It doesn't really require me to use muscle. But if I want to breathe out all the way, then that causes internal intercostal muscles and abdominal muscle walls. Okay, so make sure you know that the muscles that cause inspiration and expiration. The diaphragm and external intercostal muscles relax and the lungs recoil. As the diaphragm recoils, abdominal organs spring back to original shape, which pushes the diaphragm upward. As the lungs recoil, the pleura and chest walls are pulled inward. Increased surface tension in the alveoli decreases their volume, and intra-alveolar pressure increases to about 1 millimeter per mercury above atmospheric pressure, and as a result, the air rushes out of the lungs because there is that difference between higher concentration and lower concentration. So for normal expiration, it's just elastic recoil, but if I want to breathe out maximal expiration, then I need my abs and internal intercostals to contract. The diaphragm is the primary mover of pulmonary ventilation. Contraction pulls it downward and enlarges the thoracic cavity for inspiration, relaxes for expiration. Okay, internal and external intercostal muscles play a role in inspiration. It's the external, and expiration, it's the internal. Now, the respiratory volumes and capacities are something that you should probably know. You do have to memorize these values. So spirometry is the study of various air volumes that move into and out of the lungs due to different degrees of effort. One inspiration followed by expiration is called the respiratory cycle. So let's look at these volumes. So tidal volume is about 500 milliliters, so half a liter. Volume of air that enters or leaves the lungs during one respiratory cycle, in and out. Okay, that's 500 mLs. The inspiratory reserve volume, which is the volume of air that can be inhaled in addition to the tidal volume during forced inspiration, averages about 3,000. So let's say I breathe in normally. Okay, that's about 500. But if I breathe in more, I just went from 500 to 3,000 mLs, 3 liters. So that's my inspiratory reserve volume. Now, expiratory reserve volume of air that can be exhaled during a maximal forced expiration. So let's say I take a deep breath in and then I can breathe out about 1,200 mLs. The volume of air that remains in the lungs, even after I've breathed out all the way, is about 1,200 mLs. That cannot be measured with a spirometer, so it's roughly about 1,200 mLs. So you always have that residual volume. Now, we have capacities, right? So now you put 2 and 2 together. So the inspiratory capacity is my tidal volume, which is 500 mLs, plus the inspiratory reserve volume, so that's about 35 total, because it's 3,000 plus 500. The functional residual capacity is volume of air that remains in the lungs after resting expiration, so that's about 2,300. Your vital capacity is maximum volume of air that can be exhaled after a maximal inspiration. So maximal in and maximal out, that's about 4,600 mLs. And your total lung capacity, the ability of your lungs, is the total volume of air that lungs can hold. That's the vital capacity plus residual volume is roughly 5,800 mLs, but that can vary with age, gender, body size. And then you have this anatomical dead space, and is the volume of air remaining in the bronchial tree. So you should know this respiratory volume. So again, you breathe mostly here, tidal volume, which is about 500 mLs. Okay. Here's your inspiratory reserve volume. Here's your vital capacity. Here's your inspiratory capacity, and here's your total lung capacity. Okay, and then residual volume is here. So again, you should probably memorize these numbers. Those are great quiz questions. So again, to review, tidal volume is around roughly 500 mLs. Volume of air moved in and or out of the lungs during a respiratory cycle, so that's normal. Your inspiratory reserve volume is about 3,000 mLs, so 3 liters. Maximum volume of air that can be inhaled at the end of a resting inspiration. Expiratory reserve volume 1,100 mLs. Maximal volume of air that can be exhaled at the end of the resting expiration. Residual volume is about 1,200. Volume of air that remains in the lungs even after maximal expiration, so you always have about 1,200, 1.2 liters. Vital capacity is tidal volume plus inspiratory reserve volume plus expiratory reserve volume, so it's roughly 4,600 mLs or 4.6 liters. Inspiratory capacity is 3,500 mLs, maximum volume of air that can be inhaled following exhalation of resting tidal volume. Functional residual capacity is 2,300, and your total lung capacity is the total volume of air that the lungs can hold. That's vital capacity plus residual volume. So that's 5,800 or 5.8 liters. So please review this. I think that'll be very beneficial for you.